So the next one we're going to do is look at hearing. Now, again, this is part of the service that I do here in Nottingham. As before, lots of senses. This time we'll look at hearing. The difference with hearing is we're now actually measuring, the brain is perceiving changes in air pressure. So air molecules vibrate, and as they spread out, they become rarefied. As they come together, they condense. And waves of these air pressure differences is what we pick up as sound. So unlike light, this can't travel through a vacuum. It needs particles in the air to move sound through the medium. We can express sound as frequency. So how often do you get these waves of rarefaction and condensation? And we can also express that in this graphical called fast Fourier transform. And so for each of these different frequencies, we have a single line based on frequency and amplitude. So that's how you can express sound as well. Now, the way that we perceive sound, again, isn't linear, it's logarithmic. So the difference between the quietest sound that we can hear and the loudest sounds that we can cope with has got a huge change in pressure. So from 2 times 10 to the minus 5 up to 20 or more before damage occurs. So we've got a logarithmic way that we respond to pressure. And so to make that easier to deal with clinically, we convert it into a decibel form. And so now we say that the very quietest that we can hear is 0. And using this notation, 120 starts to become really uncomfortable, and probably 130, 140, 150, we're talking instant damage. So the way that we notate sound and hearing is in decibels, and decibels is logarithmic. Now, with hearing, we've got the external structure, we've got a middle ear, and then we've got the inner ear. Now again, like with vision, all of this structure is designed to get this property of the environment, or sound pressure, into this part as efficiently as possible. So this is where the sound is detected in the cochlea, and all of this structure is to deliver it there in the best way possible for us to use it. We've got 2 ears. Now, in most parts of the body, we have duplicates, 2 kidneys, we have 2 eyes, we have 2 arms, 2 legs, and that gives a bit of redundancy. So if one breaks, we've got a second. But another use of 2 ears is that it allows us to tell where sound is coming from in the horizontal plane, left, right. Because if you have a high frequency sound over to one side, it will hit one ear before the other, and it will hit the closer ear louder than the other. And so the brain can take the signal from each ear and work out where that sound came from in space. That only works though in the horizontal plane. It doesn't work above and below. And it doesn't work for sounds that are directly in front or behind, because in both of those situations, each ear will be hit simultaneously. It also breaks down with very low frequency sound, because as the wavelength of the sound increases, it will then hit both ears the same. So that's why if you have a home cinema system, it's quite important where you place the treble speakers, but it's not important where you put the subwoofer. The subwoofer can go anywhere in the living room and you won't be able to tell where the sound is coming from in space. But with the treble speakers, you can. Now, the shape of the outer ear is useful because that modifies the sound as it comes in. And this shape allows us to tell the difference between up, down, front, back. So that's how we localize sound above us, below us, in front of us, or behind, is the shape of the 2 ears. Now, in physics as well, the concha, or the bowl of the ear, together with the ear canal, takes sound waves and enhances them because of resonance, down to the physical properties and size and shape. And this graph along the bottom shows how it boosts up frequencies of certain frequency. And luckily, these frequencies are the most important for us for speech. So purely the passive shape of that device enhances speech frequencies, just by the property of its size and shape, without doing anything else. Now, when these vibrations come down the ear canal, the vibration is in air. And the sensory cells that we've got that live in the cochlea live in fluid. And between the two, there's a membrane called the oval window. Now, if we were to allow these air pressure waves to hit that window directly, because this is high impedance compared to air, most of the sound pressure would bounce off and it wouldn't actually go into the structure at all. Now, some amphibians have got that situation. With some amphibians, the actual window that goes into the cochlea lives on the outside of the head, and most of the sound pressure doesn't actually enter the cochlea at all, it just bounces off. So what we've done to address that situation is we have this cavity called the middle ear. And so now the air pressure that comes down the ear canal hits the eardrum, and then these bones transfer that vibration to the oval window. And this cavity has got the same air pressure as the outside world. And that air pressure is regulated by this tube, which is the eustachian tube that goes to the back of your throat. So every time you swallow, or every time you talk, this tube opens and allows the pressure to equalize across your eardrum. So if you go up in a plane, the reason you want to pop your ears is because the air pressure outside drops, the air pressure behind your eardrum doesn't. Your eardrum then pushes outwards, which becomes uncomfortable, so you swallow. When you swallow, you open this tube and equalize the pressure. Until you do that, you find that your hearing gets dulled, because if there's a pressure in there that's different to the outside, this doesn't work efficiently. So you need to equalize the pressure for this middle ear to do its job. Also, if you get a heavy cold, then this tube will tend to block up. If this tube blocks up with a heavy cold, it means that the cells that line this tissue start to suck out oxygen. So you get negative air pressure in here, which pulls the eardrum inwards, which then again makes this less efficient. So your hearing becomes more muffled. So that's why you get muffled hearing with a heavy cold, and why it then makes you want to pop your ears. Now, the way that this middle ear is working, in order to get the sound into the cochlea, into the fluid, it's got three mechanisms. The first one is the tympanic membrane is a lot larger than the oval window. So there's an area difference. And that boosts up the pressure by 17 times, just that area change. So air molecules hitting that surface get transferred to pressure onto that much smaller surface. Also, the eardrum is cone-shaped. It's not flat. So when sound pressure hits it, there's a buckling effect, and that doubles the sound just by the shape of the eardrum. And then the third factor is the middle ear bones that transfer the vibration. They act as a lever. So the way that they're structured means that they also increase pressure by a lever effect. So those three features magnify the pressure by 45 times approximately, which then gets the vibration in air into the cochlear fluid as efficiently as possible. Now that's fine if this structure is working, but if you get a change in air pressure in there, it will affect it. If you get a perforated eardrum, it will affect it. If these little middle ear bones start to seize up, it will affect it. Or if the bones break. So anything that affects this middle ear will affect hearing. So then if we go into the cochlea, it's like a snail shell. And there's three chambers. There's a top one, a bottom one, and a middle one that run up the whole length of this snail shell. And if we just take one cross-section and take a closer look at it, we have the top tube and the bottom tube, which are actually joined together right at the apex of that snail shell. So these two share the same fluid called perilymph. And the middle tube, it's like a tube inside a tube, this has got different fluid called endolymph. And the different ionic composition of these two fluids creates a big battery between that one and this one. So there's a big battery of about 80 millivolts sitting in the cochlea. And in between that battery, there are these cells, and these are the sensory cells. So the top of the cell is sitting at 80 millivolts. The bottom of the cell is 0. So there's an ionic difference waiting to rush into that cell that would then generate a charge. And sitting on top of those cells, there are little hairs. And if the hairs bend in one direction, it opens a pore that lets these ions rush in. And if the hairs bend in the opposite direction, it closes the trapdoor, which stops the ions. And so as the vibration comes into the cochlea, the hair cell starts to vibrate. As the hair cell vibrates, it opens and closes a little trapdoor. As it opens the trapdoor, the ions rush in, the cell then fires, and the signal goes off to the brain to say you've heard something. Now, the oval window that we talked about makes contact with this top tube, the scala vestibuli. Now, the fluid inside the structure is non-compressible. It's like brake fluid in a car. So if we try to put pressure wave into that cochlea, it wouldn't work because it would be seized up. The fluid wouldn't move. So in order to allow that membrane to move, there's a second window called the round window, and that connects to the skeleton point. So if we put pressure into the top window, it will be transferred out the bottom window. And there's two ways this could happen. Either the pressure wave could travel right way up to the cochlea, peak, go through the gap, come all the way back down again and out the bottom window. Or in between these two tubes, there's this inner tube, and this inner tube with the sensory cells on, they're sitting on a membrane that's like a rubber band. So this membrane is flexible. So what really happens is the pressure wave comes into the cochlea, it bends the rubber membrane or the flexible membrane, bypasses the rest of the cochlea, and then finds its way back out through the basal window. And as it goes around this loop, it makes that membrane vibrate. And as that membrane vibrates, it makes the hair cells at that position open and close the little trapdoors, so they fire and send a signal to the brain. Now, the property of this membrane changes along its length because of its physical shape. So at this bottom end, it's narrow and thick. And at the top end, it's wide and thin. So actually, different parts of this membrane will vibrate with different frequencies based on its resonant properties. So high frequency sound coming in will make this end vibrate more, and low frequency sound will make that end vibrate more. And so if the signal comes from this end of the cochlea, the brain knows that was a low frequency sound coming in. If the cells at this end vibrate, it knows it was a high frequency coming in. And so there you've got the vibration that's stimulating the cells. So if we relied purely on that passive membrane to tell us what the frequency were, we'd end up with this sort of arrangement, whereas we change the frequency of the sound and look at what intensity of sound is needed to stimulate the nerve fiber. Actually, you need quite loud sound to stimulate it, and it's not very sensitive to different frequencies. So that can't be the only mechanism that we use to distinguish frequencies, because we can actually tell the difference between sounds of 1 hertz. This wouldn't allow us to do that. It's too coarse. And so what the cochlea's got, as well as this passive property of the membrane, it's got these 3 cells. There's a row of these, 3 rows, that run the whole length of the basilar membrane, and these act like little motors. So this cell is the one that tells the brain that you've heard something. These cells, when these vibrate, they change the length, they kick. And as they change the length, they enhance the flow of the vibration up the membrane. And the more the membrane vibrates, the more they kick. And so effectively what happens, instead of having sequential nerves doing this in response to frequency, one nerve fiber will do that. So the top line is due to the passive property of the membrane vibrating. And then when you add in the kick of these cells, it gives you this nice sharp tuning of the response. So now, when we feed in different frequencies onto the basilar membrane, if these cells are working, what you'll find is that these cells will send really well-defined responses to different frequencies. And we can easily tell what frequency we're listening to based on which cells we're firing and the rate of firing. So you've got a passive part up here, and then this bit gives you the active part. Now this is useful to know about, because when we start to get hearing loss, the thing that tends to go first is your high frequency hearing. Then also the thing that goes first is the function of these cells before these cells. So what tends to happen is these start to degrade, we start to lose these tails. And so that means our sensitivity to hearing drops. We need louder and louder sound in order to stimulate it. But also our frequency resolution starts to decrease because we lose these sharp tuning parts. And so what happens is the patient with a sensory hearing loss will get a raised threshold and poor frequency discrimination. And so that's why people who've got a sensory hearing loss who are given a hearing aid quite often will be disappointed, because they assume that a hearing aid will correct hearing in the same way that glasses will correct vision. And it doesn't. Because what the hearing aid can do is amplify the sound, which will help us with the threshold, but the hearing aid doesn't give us back frequency resolution. So the sound isn't as good as we expect. So you have to manage the patient's expectations of what the hearing aid can and can't do. So, really complex slide. Once these hair cells kick to send the signal to the brain to say that you've heard something, it goes through a whole host of parts up to the brainstem, then up through the brainstem on both sides, then off to the brain. And then we also get signals coming back again that change the way that these outer hair cells behave. So it's a two-way communication. You have a signal going to the brain to say you've heard something, and you get signals coming back again that modify the kick that these cells give. And then eventually you end up at these parts of the brain on either side, and this is the auditory cortex. It's a lot smaller than the visual cortex. We've got a lot less brain interested in hearing. So any problem that affects sound getting into the ear canal, so if your ear canal is malformed, if it's blocked, if it's damaged, will give you a conductive hearing loss. So you'll stop the sound getting in. If there's a problem with the middle ear structure, if there's a perforation, pressure buildup, fluid buildup, bones are damaged, it will give you a conductive hearing loss. So what that means is that sound is struggling to get into the sensory cells. Once the sound gets in there though, everything works fine. So people with a conductive hearing loss, what you'll tend to find is that you need to turn sound up for them to hear. Because if the sound is loud enough to get through this blockage, they're fine. When they speak, quite often they'll speak quieter than normal because their own voice will resonate inside the head and sound louder internally than normal. So sometimes you'll find that they will speak quieter, but you will have to shout at them to be heard. If you've got a problem with the cells inside the cochlea, you'll have a sensory hearing loss. So this is not a problem with the sound getting in there, it's a problem with the sensory receptors responding once it arrives. Or if there's a problem with the nerve or the brain, you'll have a neural hearing loss. And again, this is a problem with the signal getting through to the brain or the brain making sense of it. And so this tends to be lumped together into sensory neural hearing loss. So patients with a sensory neural hearing loss will quite often struggle with quiet sounds, but because they tend to get what's called recruitment, so if the sound gets loud enough, they'll start to get a lot of these cells responding. Quite often they'll say, I can't hear you. You will then shout, and they'll flinch and say, you don't need to shout, I'm not deaf. And what they define that as recruitment. They can't hear the quiet sounds, but the loud sounds, either they can hear as normal, well, normal intensity, or they might be hypersensitive to loud sounds. So they have a real narrow range between threshold and pain, and it's called recruitment. So how do we assess hearing? First thing, we can look down the ear. So we can look in the ear canal to see, does it look open? Is it patent? Is there anything obvious that's wrong? We can see the eardrum to look if that's healthy. If there's fluid behind the eardrum, we can see bubbles through the tympanic membrane. All of that can give us a good idea of that conductive mechanism. We can also look to see how that middle ear is working. Is the eardrum moving as it should be, and what's the pressure behind the eardrum? The way we do that is a technique called tympanometry. So we place a probe into the ear to make an airtight seal. We play a sound into the ear canal, and we measure the sound that bounces off the eardrum. And while we're doing that, we change the pressure in the ear canal. So if we have the pressure on each side of the tympanic membrane as equal, we'll have the least sound bouncing back because the eardrum is its most floppy. As soon as we make the pressure in the canal negative or positive in respect to this cavity, we'll make that eardrum stiffer. And as we make the eardrum stiffer, either by pulling it in or pushing it out, more sound will bounce off. And so the device will see a louder sound coming back. And so it actually prints the reciprocal, but in this case, the peak represents less sound coming back. And so with this top corner one on the left, we've got a normal response. So it's saying that the pressure behind the eardrum is atmospheric. And it's saying that as we sweep the pressure negative or positive, we get more sound coming back to us. And the height of the peak tells us how well the eardrum is moving between fully locked and fully flaccid. And the next one's down, you see the peak has moved over to the left. So that's saying in order to make the eardrum move, we need to put a negative pressure in the ear canal. So that tells us there's negative pressure behind the eardrum, which tells us the eustachian tube is probably blocked. And then with the next two, not only is it negative, but the peak is getting lower and lower. And that tells us that even if we get the pressure right, then the eardrum doesn't move very much. And so that tells us there's probably fluid or glue behind the ear. So this is glue ear in children. Then on the right side, the top one, the peak has gone off the top of the scale. So that's quite common if the bones are broken. So the membrane is just too mobile, it's floppy. And then the bottom one, the pressure is normal, but the eardrum's not moving very much. And this could be that the eardrum's gone stiff or the middle ear bones are fusing. So they're not allowing the tympanic membrane to move. So all of these would give you a conductive hearing loss. Perception. With very young children or babies, or young children, we can play sound that's a calibrated sound source and look for the baby to make a response, either turning for the sound or turning to look at toys in response to sound. If we do this type of testing, because we're playing a sound into a room, we can't use a pure tone, because a pure tone will hit the wall of the room and bounce back, and we can then get constructive and destructive interference, which will change the intensity at different points of the room. So if we're playing sound into a room as a test source, we'll have a warble tone, and the warble tone wobbles in frequency, and that stops these standing waves, which means that we're more confident about the sound intensity. If the patient's older, we can do a really simple test of the tuning fork. So take a tuning fork, strike it, place it on the midline of the head, and ask the patient where the sound sounds loudest. If the sound is loudest in the middle of the head, either both ears are fine or both ears have got hearing loss, but it's symmetrical. If they say the sound is louder on one side or the other, either the sound on the side that's loudest, that ear could be conductive, or the sound on the side where the ear, it's quieter could have a sensory hearing loss. So this just tells us there's an asymmetry. So one ear could be conductive, or the worst ear could be sensory, we don't know. So that's where the second test comes in. So we strike the tuning fork again, press it on the bone, ask them to listen to it, then present it to the ear canal, and ask them which one was louder. If they are normal, then this air conduction one should be louder than bone conduction. If they've got a conductive hearing loss, then the bone conduction one will be louder than air conduction. So this test will tell us there's an asymmetry. This test on each side will tell us whether one ear is conductive or the other ear is sensory. So it's a really, really quick and simple test. It's really inexpensive. But the limitation is you're only using one frequency of the tuning fork, and it doesn't tell you about a loss in both ears, unless it's really bad. So to address that, then we have audiometry. So pure tone audiometry, we have a device that presents calibrated sound, and it's a calibrated intensity and a calibrated frequency, and we can present it through air conduction through a headphone or an insert, or bone conduction by a vibration. And we can test the hearing at all different frequencies and intensities to see what the patient's threshold is. We can calibrate the sound to international standards. So a hearing test done anywhere in the world should in theory give the same results, because it should be calibrated to an international standard. And the reason we need to calibrate is our perception of sound changes with frequency. So at threshold, we're more sensitive to high frequency or mid to high frequency sounds than higher or lower. And so what we do is we take this profile and we adjust any results table to give a flat line. So on the audiometry table, 0 is average threshold in normal healthy individuals at each frequency. And so we can do that with air conduction, which are the circles or the squares, bone conduction, which is the triangles or these C shapes, and we can pick up normal hearing. If there's a difference between air and bone, it tells us a conductive problem. If the air and bone are both raised, it tells us there's a sensory problem. This is a classic pattern for age-related hearing loss, high frequency. I've gone first. And so that can tell us a lot about how good the hearing is what the frequency response is, and it can give us some idea of why the problem might be there. The issue with pure tone audiometry, though, is these sounds are very simple. They're sine waves. And people might say, well, I'm okay with simple sound, but I really struggle with speech. So if I'm at a party and somebody's talking to me, I can't hear them. If I go into a quiet room with them, I'm fine. I can hear. Or if I'm on the telephone, I can hear better than if I'm in a group situation. So what we can do is try them with speech. So we can give them speech words of calibrated intensity. Each word has got 3 phonemes, a beginning, a middle, and an end. And what we do with the list is we ask them to tell us what they heard. And we give them a score, depending on how many bits of each word they got correct. We can then plot that score out of the percentage correct against the sound intensity, and we can use this to compare it against their pure tone threshold. And this can then tell us whether their results with speech tie in with the pure tone, or if it's a lot worse, it could well be a problem with the nerve or the brain, say a tumour, where they can perceive simple sounds, but they really struggle with complex sounds. Objective performance. So again, we've got tests where we can objectively assess these structures. The first one, acoustic emissions, looks at the function of these cells. And the reason that's useful is that these tend to be the first to get damaged with hearing loss. Because this doesn't rely on the patient doing anything for us at all, we do this test on newborn babies. So a lot of countries do a universal hearing test on babies. So in the UK, every baby that's born is tested with this test. And then if the test gives satisfactory results, the baby can be discharged. If not, they go on for further testing. Essentially, with a transient otoacoustic emission, we play a click that's got lots of frequencies in there. The click gets played into the ear canal. It passes into the cochlea. If those oto hair cells are healthy, they kick. Some of that kick is non-linear. So some of that kick leaks back out of the ear in the form of tiny sound. So we play the click in, and then we record what comes back out again. And we can look at the frequency content to say, oh, we're getting the frequencies coming out that went in. And so there's a response from me. There's the stimulus going in. That's the frequency, that's the waveform of the click. This is the wave, it then waits for 4 milliseconds to get rid of the stimulus, and then it records sound in the ear canal. And there's the recording, and it will then look at those 2 waveforms superimposed and say the correlated, which is the blue, and the uncorrelated, which is the red, with different frequencies. And it's looking for a signal to noise greater than a certain level to say, yes, we've got an emission at that frequency. Over here is a case where there's no emission. So you've got a nice stimulus going in, but no wave coming out, and no correlated response, so there's no response. The limitation of otoacoustic emissions is that sound has to go through the middle ear twice, on the way in and on the way out. So any problem with the middle ear really affects this test badly. Also, this is not giving you any information about threshold. If you get a response to emissions, that's good. If you don't get a response, the hearing could be anything from about 30 decibels to nothing. It doesn't tell you what the hearing is, it just tells you it doesn't hit that threshold of expected level. Another emission type is called distortion product. With this one, the stimulus is actually 2 pure tones that are played in simultaneously. The 2 pure tones are a different frequency, F1 and F2, and what this relies on is the theory of distortion. Those outer hair cells are non-linear. And if you play 2 pure tones into any nonlinear system, it will distort. It gives you buzz. And the frequencies of that buzz are predictable because the frequencies are based on the frequencies of the stimuli. So with distortion product emissions, we play 2 pure tones in, and we look for amplitude of response at a 3rd frequency that's related to these 2 frequencies. And then we plot out that, and then we move the 2 stimulus frequencies, measure and plot, move them, measure and plot. And so we get this type of display. The advantage of this method over the transient is because this response is a different frequency to the stimuli, we can record this at the same time as stimulation. So we can put more energy into the cochlea. We don't have to stop and wait. And so we can get responses from the hair cells at higher levels of damage than we can with the transient. Also, because we're putting in 2 pure tones rather than a click, we can test at higher frequencies, because a click only goes up to a certain frequency and then the energy dies off. Pure tones, we can go to whatever frequency we want. And then the third type of an emission is called a spontaneous. With this one, we pop a microphone into the ear, and we either just listen to what it can pick up, or we stimulate the cochlea with a click, and then we listen for a long time after. And what this is doing is just looking to see if any of those hair cells are resonating. Now, originally they thought that this might be related to things like tinnitus, where people can hear sound that isn't real. Actually, there's no correlation. So this is not that useful clinically. The only use really is if you've got a spontaneous emission and it then disappears, it suggests that something's happened to make it disappear. So maybe you've got damage in there or a drug effect or something. Next one in is Ecog. This one also looks at those hair cells, and with this we pop an electrode either through the eardrum onto that promontory, or we can have an electrode in the ear canal, but this gives a much smaller response. We play an acoustic click into the ear. The cells within the cochlea respond electrically, and then we detect that electrical response with electrodes on the skin surface. And now we can see the response of the hair cells, this wiggle. We can see this peak, which is the nerve firing, and we can see this bulge, which relates to the basilar membrane's resting state. This one doesn't tend to be used as much now in this form because it's more invasive, although we do a modified version of this when we test in babies to see if they've got a problem with the nerve. With that one, we don't use an invasive electrode. We use an electrode on the skin surface. Now, if a patient, we want to test the pathway up to the top of the brainstem level, we can use an auditory brainstem response. And we also use this test for any babies that don't pass the hearing screen. So a baby that's born with a high risk factor of hearing loss will have the otoacoustic emission and this test, the screening version. Any babies that refer from the screen will have diagnostic versions of these tests. And we can provide an acoustic click, which is broadband, covers lots of frequencies, or we can have a short duration sine wave, which is a tone pip. And we can have different frequency tone pips, which are more frequency specific. The sound goes into the ear canal, click or tone pip, goes through the middle ear to the cochlea. It then generates an electrical signal that goes up the nerve and up the brainstem. And as this current flow passes through the tissue, it spreads until it eventually hits the skin surface, and we pick that up with electrodes using similar techniques that we mentioned before for visual. The nerve has got lots of fibers, and it relies on all of them firing synchronously. If they're asynchronous, then the signal doesn't really travel through the tissue very well. And as we said before, there's lots of way stations on the way up to the brainstem, but with the ABR we tend to have a series of well-defined peaks, and each peak is coming from roughly different parts of this pathway. So we can use this test to say how sensitive is the hearing, or we can look at the time in between peaks to say how well is the signal getting between these structures. So in neurological terms, the top waveform there is normal, so the space between the peaks is normal. But if we damage the nerve, say we put a tumour on that nerve and press it, you'll find that the time in between the first two peaks gets longer, and then after the blockage, they're all normal again. If we were to take damage higher up, say a brainstem tumour, then all of the peaks up to that damage would be normal speed, then there would be delay, and then the peaks would carry on again. So this is neurological use of this technique. For hearing, what we do with that one is we play sound of different stimulus intensities, and we measure what stimulus intensity do we need to just get a repeatable response of a threshold intensity. Now, whereas with vision we were talking about a few hundred microvolts, at threshold for the hearing test, we're talking about anything more than 40 nanovolts. So these signals are really small. So these are very, very difficult to get. We have to be careful with housekeeping to pick signals up this small. Then to take us further up the pathway, we can look at what the brain does. Because we're testing what the brain does to sound, we can now have longer stimuli, which means that we can make them more frequency specific than we did with pits. These are called tone bursts. So we play maybe 1 a second or 1 every other second. The signal goes up to the brain responds, we pick it up with surface electrodes. And so we're actually just testing more of the pathway. And we've got an example there. So going in with 50 decibels, we get a response, and we keep turning it down until the response disappears. And we're looking at the lowest sound level where we can get a reliable, repeatable response from the brain. So that's hearing. Because of what we said earlier when you were asking Dan about the role of scientists and engineers, and I've just added this one quickly. In my own practice, I'm responsible for an evoked potential service and medical physics. And what we effectively do is we help the medic to determine what's wrong with their patient. So they will refer a patient to us and either ask things like, can you tell me if there's a problem or not? Can you tell me where the problem is? Or I know there's a problem, can you tell me how bad it is? Or they may say, the patient features could be one of a few conditions, can you help me with differential diagnosis? Or we know this patient's got a problem and it's a progressive problem, can you tell us how bad it is at this time? Has it got worse? Has it got better? Is treatment working? So we will help with those type of questions. Now, what we do is we're actually quite autonomous. So we run the clinic, we prioritize the patients, we will book the patients to come in, we will decide which tests to do on the patient based on the referral and their clinical history. We also decide on which equipment our service should buy, and we make sure it's calibrated and we make sure it's working properly. We make sure it's set up using the appropriate protocols. We then test the patients ourselves. So patients will come in and we will physically do the tests, or we'll supervise people who are doing it for our behalf. We will then make sure that the data we're getting is good and usable. We will then interpret that data based on any other factors. So has the patient got cataracts? Have they got problems that might affect the data? And then we will actually pull all of those results together and come up with a clinical report from the consultant to say, in our opinion, this is what we found. So we're responsible as clinical scientists for all of that. So making sure the service is appropriate, meets its targets, is operating to recognised standards, and providing the clinicians with the advice they need. So we can do all of that as part of medical physics and clinical science. So that's audiology. Well, a whistle stop tour of audiology.
Thank you very